Hi, everybody. My name's Justine. I'm the president of Youth for Health Equity, and today we have Dr. Paul Ross, an OBGYN, speaking with us. So without further ado, Dr. Ross, go ahead.
Hi, everybody. First thing I'd like to do is acknowledge Justine for putting this whole thing together. I think it's really an incredible achievement for anybody, let alone a high school student. It's really pretty amazing. I'm very, very impressed. And also want to thank everybody that's listening in, giving up part of a Saturday to listen in. And I'm assuming that there are quite a number of people that have interest in medical as a career, and hopefully I can address some issues there and take away some of the mystique, answer some questions for you. So my professional organization is called the American College of Obstetricians and Gynecologists. It represents all of the OBGYNs in the country that are board certified, and that's about 35,000 doctors. And my college put out a policy statement on May 20th that was titled Health Equity Issues for Obstetricians and Gynecologists During the COVID-19 Epidemic. And I'm going to review that with you, answer any questions that you have about that, after I give you a little bit of backgrounding information and context information about myself so that you understand what my frame of reference is and what sorts of things I'm capable of answering or not answering after we're done with the talk. So I was born in 1949 in Batavia, back when dinosaurs still roamed the earth. And I grew up in a very unusual bubble that I would say was very free of racism and racial bias. Batavia at the time was a pre-Fermi lab, sleepy little agricultural community, totally surrounded by farms. We had an east side and west side of town. On the east side of town lived most of the people of color. On the west side of town lived most of the Caucasian population, but you couldn't tell the difference between the two sides of town just by driving through. Everything looked exactly the same, the homes and everything else. At the time, I would say the demographics for Batavia were 80 to 90% of the population were of Swedish heritage. So pretty much everyone in town was a Anderson Johnson, Peterson Swanson, Hubbard, Ekman. And Swedes are extraordinarily welcoming, kind, unbiased people. So even though my family was the only Jewish family in town, I never experienced a molecule of anti-Semitism growing up, and I never witnessed any racism or bias towards any town resident. We had a drugstore that had a lunch counter, and I know you won't have a frame of reference for this, but back in the 50s, there were lots of parts of the country where African Americans couldn't go sit down and have lunch sitting next to Caucasians, but in Batavia, everybody sat at Johnson's drugstore counter, just like normal interactions. It was kind of a Norman Rockwell upbringing for me. We had Dalmatians that rode on the fire truck with the firemen. People treated each other with kindness and respect. People watched out for their neighbors. Everybody knew everybody else. I had a high school class of, I don't know, maybe around 100 kids. About 10 of them were African Americans. The president of my class was an African American. One of my best friends in high school was a guy named Danny Davis, was also an African American. I just grew up in a weird, surreal bubble where everybody treated everybody with respect. So after graduating from high school, I went to University of Wisconsin for college and then on to medical school. And by the time you reach your third, fourth year of medical school, people need to be seriously deciding on what kind of physician they'd like to be, what they'd want to specialize in. And sometimes people will ask me, when did I know I wanted to be a doctor? I've always wanted to be a doctor. My earliest memories as a toddler had me wanting to be a doctor. I don't know why. My father was a physician, he was a psychiatrist, and we had a lot of journals and medical artwork and things around the house that just always fascinated me. Human body always fascinated me. I always wanted to be a physician. None of my siblings, but there was me. And when I started thinking about what type of medicine I wanted to specialize in, there were some special issues that were unique to me. Number one, my father had an extraordinarily rare spinal cancer that slowly and extremely painfully killed him over a number of years. He died when he was 54. So I knew that I was not going to be very good taking care of people who were chronically ill. Hats off to the internists who are caring for the chronic renal failure patients and the COPD patients and the brittle diabetics and the people with ongoing cardiac issues. But that wouldn't be right for me. I wouldn't be, I realized, a good doctor caring for people with chronic problems because of the life experience I had with my dad. So you think about obstetrics and gynecology. It's the only branch in medicine where people, at least for the obstetrics part, go to the doctor and get something nice at the end. I found that very appealing. There's also this interesting dichotomy in medicine where you have basically medical practitioners and surgical practitioners. You know, you have the internists that take care of the complex medical problems, and then you have surgeons who do the surgical interventions. And you know, the joke in medical school that someday you'll hear is that internists know everything but can't do anything. Surgeons can do everything, but they really don't know anything. But in obstetrics especially, and I think for OBGYN, even though we get trained in both, most people decide pretty quickly whether they'd rather focus on obstetrics or focus on gynecology. And for me, absolutely the interest was in obstetrics. The first time that I saw the birth of a baby, it was the most mind-bending, mystical, magical experience of my life up to that point. And every subsequent time that I saw the birth of a baby, it blew my mind in exactly the same way. You think about it, you start out with 2 cells, an egg and a sperm, they come together, and 280 days later, you've got a whole new person popping out of the body of somebody else, which is awe-inspiring. So having the opportunity to be part of some kind of miracle like that on a daily basis was really appealing. The fact that obstetricians deal with complicated medical problems to figure out, just like the internists, but we're mostly taking care of normal, healthy, younger people. So you push all the right buttons, you provide care in appropriate ways, or you provide a surgical intervention, and sometimes they're life and death. But you do the right things, and most of the time people get better. So I found that very appealing, the fact that I could be both a medical doctor being challenged by medical issues and also a surgeon. So what you'll find as each of you are going through medical school is when you make your choice ultimately about what you want to go into, training programs for different things are of varying lengths. So for obstetrics and gynecology, there's a standardized 4-year residency. Residencies are skilled, supervised, on-the-job training that lasts for a given number of years. For me, it was 4 years. For, say, a person that would like to go into family medicine, it's 3. General surgeons, it's 5. Psychiatrists, it's 4. And at the end of each physician's training period, there's a board exam or board exams. For me, it was an oral and a written exam. And once those are passed, you become a fellow in that particular college. College is a confusing word because it's got 2 definitions. One is that it's an institution of higher living, and another is that it's a group of professional people who have certain goals, skills, and privileges. So I belong to the American College of Obstetrician Gynecologists. Surgeons belong to the American College of Surgeons. What happens if people want to subspecialize after they have their basic surgery certification or basic OBGYN certification is they apply for another residency. So let's say I wanted to be a heart surgeon. After I do my 5 years of general surgery residency, get board certified in general surgery, now I have to do 2 more years in residency for thoracic surgery, get board certified in that, and then 5 more years in cardiac surgery, and then I can be board certified as a cardiac surgeon. Same for obstetrics and gynecology. When I started training, there really was no separate board for REI, which is reproductive endocrinology and infertility. There was no separate board for oncology. There was no separate board for maternal fetal medicine. Everybody in OBGYN was very much being trained as a generalist in their area. Now, if you became board certified in obstetrics and gynecology, you wanted to be an infertility doctor, you do an additional 2-year residency in reproductive endocrinology and fertility, take board exams, and now you'd be part of that club and qualified to act as an expert in that particular area. So I did my internship and residency at a hospital that doesn't exist anymore, Michael Reese Hospital and Medical Center on the south side of Chicago. At the time that I was there, it was a very long established, extremely well-respected institution, and its OBGYN program easily was one of the top 5 in the country. My department chairman was a very brilliant first-generation Italian named Antonio Scamegna. He was one of the first 3 doctors in the United States to be board certified in in infertility. He and 2 other very smart guys got together and created the American Board of Infertility, American College of Infertility. And for a long time, Michael Reese was an innovative mecca of infertility work for obstetrician gynecologists. And very much as the surreal, non-normal life upbringing I had in Batavia, Tony Scamegna had a completely colorblind approach to selection of his residents, selection of his house staff. So in my residency cohort, which was 5 people that went through the 4 years of training together, there was me, 2 African Americans, Silas Thomas and Faye Bomer. In the year ahead of me, in the 5-person cohort, there were 2 Caucasians and 2 African American women, Donna Pratt and Ann Ward, and Hispanic, Rufino Jimenez. The chief resident was a very outstanding Latino named Vicente Zapata, and in his cohort, there was also an African American. So we had a very racially diverse group of residents, And the Department of Obstetrics and Gynecology, at least, was completely integrated, and people treated each other with respect. We had an inner city population. I never heard the N-word. I never saw anybody treat anybody with anything but the highest respect and regard. It was a very surreal, non-normal training experience for me as a young physician. And both of my mentors, the two people I wanted to be when I grew up, were both African Americans, Ann Ward and Donald Chapman. So that's my background, and that's where I come from as I survey the issues of health equity in the United States. I have interacted with thousands and thousands of babies. I've held thousands of babies. I've been with thousands of babies. And I can tell all of you as an incontrovertible fact that no baby hates another baby. No baby wants to hurt or torture another baby. No baby wants to enslave another baby. No baby wants to kill another baby. No baby wants to put its knee on the neck of another baby till it chokes the life out of it. Babies love everybody unconditionally. So then, how do we get from that to where we are now? It's something that's very hard to wrap your mind around, but I can tell you how. I have listened to my wife Gilda, your next speaker, who's the organizer and coordinator and life force behind the Glenbar Parent Series and the Reality Illinois Teen Advisory Board to the DuPage County Health Department, tell hundreds and hundreds and hundreds of parents, your children will listen to 1% of what you say, but they are going to pay attention to 100% of what you do. My dad was a humanist. He was the kindest, most caring, most empathetic person I have ever known. And he lived his life according to several tenets. One was the golden rule. The other was the concept of paying it forward. And the third was a saying by Ben Franklin, which goes, the hard thing and the right thing are almost always the same thing. So it's important to follow the example of someone like Justine, who I really don't know, but just by the fact that she's put this seminar together tells me that she's a action speaks louder than words kind of person, and that she's going to be a real difference maker in the world. And if all of you put your mind to it, by your example, you can demonstrate appropriate, caring, empathetic behaviors that hopefully will become a new cultural norm. So now I'm going to go into a little bit of this policy statement by my college, the American College of Obstetrician Gynecologists, on quote unquote health equity for OBGYNs during the COVID-19 pandemic. Gilda told me don't do too much reading, but some of this is so eloquently and succinctly worded that I have to read some passages to you. And I would invite any of you who are wondering, well, why, is your college saying this? And why isn't there an organization that speaks for all doctors? Why not the AMA? Why don't they have a policy statement? And the answer is they do. But if any of you go online and review it, it doesn't sound anything like my college's policy statement. My college says up front in the clearest language that medicine in the United States is a racist institution filled with bias and compromise of disadvantaged groups in terms of health equity that is incredibly unfair, and that our job as OBGYNs is not only to attempt to undo all the racism inherent in medicine, but also to ensure that things that happened during the pandemic don't make patient situations worse. So let me just read a couple things. This is a quote from the introduction. Obstetrician gynecologists should recognize and examine the ways in which healthcare systems perpetuate unacceptable inequities in access to care and outcomes. This includes recognizing that racism and bias play a role in these health inequities. Racism and bias in the healthcare system, including but not limited to doctors, may negatively influence access to prevention, access to testing, access to treatment, and particularly when there are shortages in medical supplies, equipment, and staff. And it goes on to say, quote, in addition, doctors need to realize that our patients don't exist in a bubble, that our patients, besides their medical health issues, are experiencing new or exacerbated life trauma and challenges during the pandemic, including but not limited to loss of a job, loss of insurance, food insecurity, issues about housing, difficulty about accessing other needed supplies, and intimate partner violence. Rural areas, tribal lands, and low-income communities may have limited access to internet and cell service. And hospitals in these areas may also have unreliable internet access. There are some individuals with physical or mental disabilities, or those who are hard of hearing, or those who have language barriers, who may also have difficulty accessing the brave new world of healthcare providing options, including telemedicine and internet Zoom conferencing like what we're experiencing today. Additionally, insurance coverage where it exists for telehealth services is highly variable. And now the most controversial component of this statement, obstetrician gynecologists' prime concern should be good patient outcomes and not the ability to pay. So recognizing, this is another quote, last reading I'm going to do for you. Recognizing and acknowledging the history of discrimination, racism, and exploitation of communities of color, and the resultant distrust of the medical system. Because of this, it's important that we as OBGYNs do everything possible to make a positive impact. Efforts to build trust and improve clinical outcomes must be prioritized during the pandemic. Policies and processes designed to mitigate virus transmission need to be closely watched to ensure that their implementation does not worsen current inequities. And then this policy statement ends by making a few specific recommendations that I'm just gonna summarize for you. Basically, it comes down to evaluate, screen, and treat. So OBGYNs are directed, quote, to evaluate crisis response efforts, to prioritize ensuring that pre-existing inequities and racism are not worsened, nor are new inequities created while attempting to reduce the risk of COVID-19 exposure. In terms of screening, we are told as OBGYNs that we should screen for and document social determinants that influence and impact on an individual's health, such as access to healthcare, access to housing, access to insurance, access to a job, access to food and water and supplies and transportation services and translation services, so that we can reduce fairly and equally morbidity and mortality for our patients. And finally, obstetrician gynecologists are directed by this mission statement, quote, to remain cognizant of increased stressors during the pandemic and ensure that screening for mental health is included in all visits, that all patients are asked whether they live with somebody who they love but who they fear, and whether there's any domestic violence issues, and that we deliver clinical and public health messaging in the preferred language of each patient, and that we make every effort to use trained medical interpreters for clinical encounters with patients who are either hard of hearing or have limited English proficiency. That we, quote, maintain active, respectful, culturally responsive, patient-centered communications with patients so that we can encourage continuity of care, ongoing care. It's hard to develop trust with patients in a teleconference or a Zoom conference. You want continuity of care, you want patient follow-up, and to assess if your individual patient's healthcare needs are being met. And finally, we're directed to advocate at the institutional, state, local, federal levels for policies that support patient autonomy and promote the provision of culturally congruent care and to advance healthcare equity. And that, Justine and everybody else, I think is pretty much what I wanted to say to you all. Anybody has any questions, I'm happy to try and answer those, but I can't answer global questions about it, what every other type of doctor is doing to address issues of health equity. I can only address issues in my little corner of the universe in terms of how OBGYNs are being directed to be socially active and to be medically caring and appropriate in terms of recognizing that racism and bias exist and trying to do everything in our power to reverse existing trends and make certain that the pandemic doesn't make anything that already is in place even worse. So thanks for listening, everybody. Justine, anybody have anything else I can answer?
Yes, so the first question is, what's your view on Black Lives Matter from a medical perspective? And just adding on to that, how can medicine, how can medicine advance the Black Lives Matter movement?
I can't speak to medicine in general. That's what I tried to preface this whole thing by, because once again, there's not a lot of cross-pollination between OBGYNs, anesthesiologists, pediatricians, surgeons, ophthalmologists, emergency room doctors, whatever. I think that the first step in addressing a problem, whether it's a substance abuse or an eating disorder or a drug habit, is recognizing and accepting the fact that there is a problem. And once again, I think if you go to the AMA, lots of people would like to think the AMA speaks for doctors. It doesn't. And look at their policy statement on health equity. Nowhere does it say we're going to start from a premise that racism exists in medicine, bias exists in medicine, and now how are we going to address and fix that and make sure that it's not made worse during the pandemic. I was listening the other day to a podcast by a very bright African American who was explaining that the Black Lives Matter movement doesn't mean that Black lives matter any more than any other lives. It's just that Black lives also matter. And you don't hear on the news over and over again about African Americans who are being shot in their sleep, or playing outside, or pulled out of their car, handcuffed and thrown to the ground, including a 6-year-old, because there's a suspicion that the car that the mother is driving is stolen. Anybody who thinks that racism doesn't exist in America is nuts. So it's not that Black Lives Matter, it's that Black lives also matter as much as everybody else's lives. And I can't speak to doctors in general or even obstetrician gynecologists in general. All I can speak to is the fact that I have been through a couple of systems, place where I grew up and the place where I trained to become an obstetrician gynecologist, where there was absolute color blindness and everybody was treated with respect. And it's been a real puzzle to me for my whole 70 years of life why people can't just be nice to each other. So I am not a spokesperson for OBGYNs, but in my personal professional experience, definitely Black Lives Matter. And I don't know what the healthcare system in general can do to address that big societal issue without people each individually recognizing that there's a racism problem in healthcare. At least my college has taken that step. Did I answer your question? I'm not sure.
That was great. And so the next question that we have was, in your opinion as an OBGYN, what can doctors do to stop Black mothers of color from disproportionately dying during childbirth as compared to white mothers?
First of all, there has to be a recognition of the fact that, once again, racism exists in healthcare. And I'm not proud to say that the history of obstetrics and gynecology in the United States is probably one of the most racist stories that could be told in medicine. And it's always been a male-dominated field until very, very recently. When I was training, 95% of the OBGYNs in the country were men. And now that's been flipped on its head, and 95% of the OBGYNs in the country are women, and currently being trained are women. And I think, quite candidly, that's the only reason that a policy statement like the one I just read to you could come out of our college. I don't think a male-dominated college would ever make a policy statement saying, we're racists, and what are we going to do about that to fix it and to address issues of disparity in healthcare in this country. Women are much smarter, more empathetic, more caring, more nurturing, and I think that you will see, at least within the OBGYN community, a real push to increase access to excellent care on a completely equal basis. The reason that in communities of color and in Native American populations that there's a huge disparity in bad prenatal and perinatal outcomes is basically, access to care. And until there are more doctors willing to go into those communities and take those patients on and extend themselves, pay it forward, integrate a philosophy of the golden rule into their individual practices to provide care for people irregardless of their ability to pay or what their insurance coverage is. I'm not sure that things are going to drastically or dramatically improve, but I think that now that my particular college is in the control of women, that you're going to see a long-term enhancement in access to healthcare, which is going to in turn provide better maternal and fetal outcomes.
Great, thank you so much. We have 2 more questions. So how would you approach a colleague that is showing or has shown bias?
How would you in high school, not you, Justine, but a theoretical you, whoever answered this question, asked me this question, how would you approach a peer in the hall who is bullying somebody or showing insensitivity or racial bias? You have to be willing to stand up and say, whoa, dude, that's not appropriate. Go get some counseling. That's not right. That's not how people treat each other. Obstetrics and gynecology, especially the obstetrics part, is a very touchy-feely one-on-one experience between doctor and patient. Even in a big crisis, you know, where you need a whole team of people to take care of somebody who's got a abruptio placenta with a bleeding dyscrasia, who's bleeding out and in shock. You're still the captain of the ship. You're telling other people what to do. You're the prime interventionist. And you take care of your own OB patients. You deliver your own OB patients. You run on your OB patients. I'd say once you complete the training process, there aren't a lot of opportunities, I would say in my own experience, to observe other people committing racist or biased, unethical, inappropriate care renderings with their own patients. And at Michael Reese, where I trained, once again, we had a completely integrated department of attendings and a completely integrated department of residents. And in 4 years of training there, I never had a single encounter or interaction that required me to speak up and say something. But, you know, the people that I admire most in my own personal life are people who aren't afraid to act. My best friend's a guy named Don McPherson who runs a gymnastics club. And Don is very much a black and white kind of guy. And I've seen him in action where somebody's bullying their kid at a grocery store and he and I are shopping and he will just randomly step in between them and say, that's not right. Stop that right now. If you don't, I'm going to call DCFS because nobody should treat their child that way. I've seen him do that. So people have to be able to feel brave inside and brave enough. Once again, I'm going back to my dad now to realize that the hard thing and the right thing is almost always the same thing. And when people see something that's inappropriate, they need to step up and act. So that's my own 2 cents on that.
Great, thank you. And then our last question is, as future physicians, what are ways in which we can reflect and recognize our internal biases?
What was that book you just recommended to me, Gilda? Yeah, well,
What fragility?
the first way is to educate yourself because people may have racial biases that they don't even realize they have. So there are a lot of extraordinarily eloquent voices right now. Ibram X. Kendi, for example, the author of Stamped. Mrs. Ross was reminding me of this book called Racial Fragility. People should educate themselves about the way that inherent bias and racism has infused itself culturally into pretty much every aspect of American life since 1619, and recognize that there's a problem and educate yourself about looking at yourself and making certain that you're not contributing to the problem, and then doing everything in your power to provide empathetic, ethical, truly caring, equal, fair access to healthcare for your own personal patients, and to advocate that those kinds of changes are brought about on a bigger, more global way in this country. There's a lot of stuff needs to be done. Anyway, I just want to get back to one quick point: the icky history of obstetrics and gynecology. The fellow who has been revered for years as quote unquote the father of modern gynecology was a Southerner named James Sims, S-I-M-S, who in the 1840s and 50s pioneered a whole number of medical devices and procedures, some of which are still used today, the Sims speculum, for example, specifically directed at addressing the issue of vesicovaginal fistulas in the slave population. People who have uncontrolled explosive childbirth frequently tear open their bottoms, and thereafter, when they heal very badly, are leaking urine and poop from their vagina, which drastically reduces their value as slaves. And Dr. Sims's motivation wasn't anything altruistic. He was doing experiments on people with no anesthesia to try and improve their value to slaveholders so they could be sent back out into the fields without leaking urine and feces on themselves. And I could give you 100,000 stories of equally racist, icky, historical components of my specialty, of which every OBGYN should be ashamed. Another example would be, if any of you have read or heard of the book, The Immortal Life of Henrietta Lacks. Henrietta Lacks was an African-American woman in the 1950s who had a cervical cancer that was biopsied by the head of gynecology at Johns Hopkins, the father of modern gynecologic oncology, Howard Jones. So Howard Jones found that this woman's cells very uniquely could be kept alive and cultured over and over and over in the lab. They were immortal cells and became the foundation for much of our multi-billion-dollar drug industry. Those cells were stolen from Henrietta Lacks without her knowledge and consent, and her family, much of which is still alive today, has not benefited one penny from that theft. So, you know, there is a lot of racist ickiness that is inherent in my specialty, and I'm sure in every other specialty that currently is practicing in the United States. And once again, I don't think that change can exist unless people recognize there's a problem, there's racism, there's inequity, and then what can we do to change it? So number one, you start with yourself, you pay it forward, you show kindness to people, you don't provide care based on their ability to pay, you lead by example, and then above and beyond that, you intervene if you see, you speak up if you see something going on around you that's inappropriate. And number three, you advocate for change at the local and state and federal level. And hopefully we all live long enough so that we can see things improve.
Well, thank you so much, Dr. Ross. That was especially the book recommendations that you mentioned at the end. Would you mind putting them in the chat for us so that we can take them and write them down and share them with others?
Sure, absolutely, yes.
Great. Thank you so much, Dr. Ross. It was really great to hear from you, and especially I myself never knew about what a terrible history gynecology has. That's
it's
so
awful.
Yeah.
It's really awful. I mean, we could go back to the 1600s even, where there was a family in England the Chamberlain family, who invented obstetric forceps. Now, these days, forceps aren't used very much for delivery, but back in the day, even when I was training, they were still a valuable tool for certain deliveries. And the Chamberlains kept the invention of the forceps as a family secret to their own wealth enhancement for well over 100 years, where they advertised that they could deliver any baby for an obstructed labor. They'd go into a room, everyone would be blindfolded, they'd cover up the woman with sheets, they'd pull out the baby, and then collect a big fee and leave. And you would like to think that doctors all take the Hippocratic Oath and that our prime concern was the health of mankind and being caring, ethical individuals who maybe answer to a higher calling. But, you know, if you go back and you look at the history of medicine, yes, there's a million self-sacrificing Jonas Salks and Albert Schweitzers who have gone out into the world and made huge impact as difference makers. But for every one of those, there's probably 10 people that were self-serving and icky in their professional career, historically. You know, things are changing though. Dylan said times they are changing. When I was a little kid, you know, Christopher Columbus was a person to be revered, and Columbus Day was an enormous holiday. And now he's seen as a racist who came over he didn't discover anything. All he did was enslave people and steal their stuff and set the stage for 400 years of misery in this country, on this continent. So, you know, we'd like to think that knowledge is power, and that the more people know about how things got to be to where we are, you know, having a racist society didn't happen overnight. It's been smoldering and growing for hundreds of years. And I also don't think that everything can be undone overnight, but you know, the journey of 1,000 miles begins with just one step. So let's all just try and do what we can. And all of you can commit yourselves as you become doctors, like Justine has done today and this weekend in organizing this health symposium, that if each of you make up your mind that you want to be difference makers in your own little corner of the world, you can be. I mean, I might finish with one other corny little story that touches on that. My wife is sighing in the background. Shut up, shut up. But, you know, there's a story about two kids that are walking on the beach. And on the beach are thousands and thousands of starfishes that have been washed up by the tide and are sitting out dying in the sun. And one of the two kids is picking up starfish as he walks along and flipping them back into the ocean. And his friend said to him, "Come on, look at this. What difference does it make that you're throwing the starfish back into the ocean?" And his friend looks at the starfish in his hand and says, "Well, it matters to this one." So, you know, if each one can reach one, if people can think about not being the best in the world, but being the best for in the world, Gandhi said that, I think in the end you have a cumulative effect of kindness that hopefully washes out a lot of the other stuff. So I'm not a perfect person. I don't have all the answers, but I do believe on an individual basis that people can be difference makers.
Great. Thank you so much, Dr. Ross. We really appreciate you coming in and talking to us.
My pleasure.
Thank you once again. And it was great hearing from you.
Signing off. And you know what, people? My email is paulrossmd@gmail.com. And if anybody had any additional questions or issues that they wanted to discuss, or family issues about somebody who's pregnant, they don't understand whether they're receiving the care that they are, or whatever, feel free to email me. It's not a problem.
Great. Thank you so much for coming in. We really appreciate it.
Bye-bye. Good luck with the rest of your seminars.
And we're looking forward to also hearing Ms. Ross speak now. So thank you so much.
Bye.
Great.